Okay. For the next session, as a chairperson, we have Dr. Kapil Mahindra, Dr. Kumar Gaurav Sharma, clinical cardiologist at Dehradun and executive member of Indian Association of Clinical Cardiologists, Dr. Manoj Garela, and Dr. Deepak Jain, clinical cardiologist from Delhi. I request chairpersons to kindly introduce Dr. V.K. Dhandhania, sir, who is a renowned diabetologist in Ranchi. May I request Dr. Rajesh to kindly do the needful. May I request Dr. Rajesh to kindly do the needful. I guess some network issue is happening, that's why things are not moving.
Don't worry, Vinay, this is a part and parcel of any webinar meeting.
Welcome, Dr. V.K. Dhandhania, the consultant diabetologist and specialist in diabetology. He's working in Diabetic Care Center, Orchid Medical Center, Nagarmal Modi Seva Southern, Ranchi. He's a secretary to RSSDI Jharkhand chapter, and he's a clinical investigator as well as author to many major publications nationally and internationally, and he's a very good orator as well as a speaker. Sir, most welcome to CARDIOZONE 2020 by Indian Association of Clinical Cardiologists.
Thank you, Dr. Rajesh, for that kind introduction. Can I share my screen?
Yes, sir.
Good afternoon, respected seniors, dear friends. I congratulate Dr. Vinay Jagnany and his CARDIOZONE team for organizing a wonderful meeting, especially for a place like Ranchi. This is a really great achievement, and I'm very thankful to the whole team for giving me this opportunity. I'm going to talk on a very important topic, management of persistent hyperglycemia in type 2 diabetes. What do you mean by persistent hyperglycemia? Is patient is remaining uncontrolled for a very long time and is not achieving his reasonable target of glycemic control. So this is a patient who is on glimepiride and metformin 2 grams for 3 years. He's a 45-year-old male, diabetic for last 4 years. And if you see the parameters, his HbA1c is 8.8%, LDL is 175, body mass index is 32, eGFR is 102, and blood pressure is 150/90. So if you see the number of risks which this gentleman has, he's got an uncontrolled diabetes, his LDL is very high, he's obese, and his blood pressure is high, and he's having last 3 years, he's not been having a targeted HbA1c control. And treating patients with type 2 diabetes means controlling HbA1c and preventing micro and macrovascular morbid condition. So this is very, very important to understand is you just need not correct the numbers of blood glucose levels. You need to actually focus on preventing both micro and macrovascular complications. And if you see, almost 50% of the diabetics develop microvascular complications within 10 years. And we have data from UKPDS in type 2 diabetes and DCCT in type 1 diabetes that if you achieve a HbA1c goal of less than 7%, almost 50% of these microvascular complications can be prevented. So this is a huge number which is preventable. 33% patient have got a risk of heart failure. This is again a very big issue which is coming up, and it's been said today that heart failure is becoming more and more common in type 2 diabetics, even commoner than CAD. Stroke is 72%, increased risk of ischemic stroke compared to those without type 2 diabetes, and 54% have got MI, which is an increased risk of MI compared to those without diabetes, almost twice as common in diabetics versus non-diabetics. So prolonged hyperglycemia as a result of delayed treatment intensification may be associated with an increased risk of CV events. And if you see in a UK retrospective observational study, delay in intensification by 1 year in consumption with poor glycemic control significantly increase the relative risk of composite CVE, that is the cardiovascular endpoints. So if you see that there is an increase in MI by 67%, stroke by 51%, heart failure by 64%, and composite cardiovascular endpoints by 62%. So the hazard ratio is very, very high. It's almost more than 1.5. So type 2 diabetic patients, poor glycemic control coupled with elevated BMI and blood pressure is associated with a greater risk of CV complications. And if you see the takeaway from the UKPDS was that each 10 millimeters decrease in mean systolic blood pressure was associated with an 11% reduction in the risk of myocardial infarction. And both overweight and obesity independently increase the risk of chronic heart disease and cardiovascular disease in patients with type 2 diabetes. To add to this, we had a very interesting study of probably 120, 130 patients, STENO 2 study, where they had this multifactorial approach. They targeted body mass index, they targeted blood pressure, they targeted blood sugar, they targeted lipids, and they followed them up. And at the end, they could, after more than 10 years of study, they found that in the intensive arm where the control was very intensively managed in all the components, lipids, blood pressure, blood sugar, body mass index, the mortality was even reduced by almost 30%. So this is what we are trying to address in a diabetic, that you need to have a multifactorial approach from day one of diagnosis. Non-adherence to treatment is a significant issue in type 2 diabetes that leads to poor glycemic control, increased hospitalization, and increased medical cost. And new combination therapies which reduce pill burden have the potential to improve adherence. And this is very, very interesting to see that a patient just tends to forget or tends to ignore the number of tablets he has got. Or if he has got one tablet a day to take, then he is definitely going to be more adherent and more compliant. And if you see here that the fixed dose combination, almost 61% patients achieve their glycemic control compared to free-form and step-by-step approach of increasing the number of medicines. Similarly, the average post-index all-cause and diabetes-related cost was less with FDC compared to the free-form and step-by-step. In a retrospective claims database analysis, treatment with FDC is type 2 diabetes was associated with lower healthcare resources utilization and cost and better likelihood of HbA1c goal attainment. So hence, what do we do in our type 2 diabetic patients? Glycemic control, you need to fix the target for a patient in front of you. This is called as individualization. Patient who has got an established CAD or undergone a CABG, an elderly man, less than 7.5% HbA1c is good enough. Or patient who is young, like our patient of 45 years old, you can keep a HbA1c target of even less than 6.5%. Weight management is very, very important. Like a patient has got a body mass index of 32, which is not acceptable. Managing comorbidities like hypertension and safety, including low hypoglycemic rates. So all these parameters are very, very important when you are actually addressing management in type 2 diabetes. So what is preventing us from the treatment intensification? Most of we people are actually having limitations in intensification. The reason being severe hypoglycemia. We are scared that our patient may land with hypoglycemia. And if you see the three important landmark studies, the advanced studies, the ACCORD studies, and the VADT, they all try to keep HbA1c less than 6.5 in a 7 to 10-year-old diabetic. And the percentage of people having hypoglycemia in the intensive arm was pretty high in all these three studies, except advanced where it was 0.7 compared to 3.1 and 3.0 in VADT. So severe hypoglycemia is associated with a 3.4-fold increased mortality risk. So what is the rationale? Now we are going to talk about this fixed dose combination, a rationale for dapagliflozin and saxagliptin combination. The drugs, they are drugs with different mechanism of actions, are required to address the numerous type 2 diabetes pathophysiological defects, decreased insulin secretion from the beta cells, increased glucagon secretion, and increased hepatic glucose output, decreased incretin effect, increased lipolysis, increased glucose absorption, decreased glucose uptake in the muscles, and neurotransmitter dysfunctions. This is what is the ominous octet, which was well presented by DeFronzo in 2009. There's a Benton Best Lecture Award by DeFronzo in 2009. And all these are the pathophysiological defects in type 2 diabetes. And if you see dapagliflozin, which is an SGLT2 inhibitor, it addresses at the level of kidneys. If you see saxagliptin, which is a DPP4 inhibitor, it addresses at the level of beta cells. It addresses at the level of decreased incretin effect. It addresses at the level of increased glucagon secretion. And if when you combine with metformin, the hepatic glucose output has been addressed. And the metformin also takes care of the decreased glucose uptake at the level of muscles. Almost 80% of the glucose is been disposed by insulin at the level of skeletal muscles. So most of the pathophysiological defects are addressed with this combination along with metformin. Dapagliflozin and saxagliptin combination has favorable effects. If you see here, DPP4 inhibitor, which is saxagliptin, the hypoglycemia risk is low, weight is neutral, CV safety is good, it's non-inferior, and systolic blood pressure is neutral, does not have any advantage of systolic blood pressure. If you see SGLT2 inhibitors, hypoglycemia risk is low, weight is causes weight loss, CV safety is well documented, and systolic blood pressure, if you see, it reduces systolic blood pressure. So when you combine these two drugs, there is another advantage of combining these two drugs. SGLT2 inhibitors are known to increase endogenous hepatic glucose production by increasing the level of glucagon, which is taken care by DPP4 inhibitors. So these combinations actually addresses the synergistic mechanism and actually neutralizes the side effects which has been seen by SGLT2 inhibitors. You see the clinical data, randomized controlled trials providing efficacy and safety. Dapa plus Sexa achieved better glycemic control with low risk for hypoglycemia versus glimepiride, and it is very, very known that both these drugs, saxagliptin and dapagliflozin, are not known to cause hypoglycemia compared to glimepiride. And if you see the percentage of people getting hypoglycemia is pretty high with glimepiride metformin, especially in high-risk populations with comorbidities, elderly population. There's a very high risk of getting hypoglycemia with glimepiride and metformin. Decreased body weight and systolic blood pressure with Dapa plus Sexa versus glimepiride. If you see, there is a 4.06 kg weight reduction as compared to glimepiride and metformin. The weight reduction is 4 kg. So this is a very good advantage with this class of drug. And there is almost 4 millimeters reduction of systolic blood pressure with this combination. So if you see, there is a reduction in blood pressure, there is a reduction in body weight, there is a reduction in incidence of hypoglycemia. So all these things are very good advantages with this class of drugs. So glycemic control as good as insulin minus hypoglycemia. This is not to replace insulin therapy. This is just in patients who have an HbA1c between 8 and 9, where you can put this combination of drugs instead of insulin, and you will find that the HbA1c control is as good as insulin plus metformin, and at the same time, there's less chance of hypoglycemia. This is not here to compare the efficacy of insulin versus the combination of this particular drug. Insulin can be is very, very efficacious. It can be even given to it should be used in patients who have higher A1C values like more than 11 or 11.5. There we cannot substitute Dapa plus Sexa combination in place of insulin. So you need to understand this is not a substitute for insulin. This is just to use rationally in place of insulin where a patient has got an HbA1c between 8 and 9. Plus a weight benefit of 3.6 kgs compared to insulin. So we know that insulin causes little bit of weight gain, whereas Dapa and Sexa causes dapagliflozin causes weight loss. So what is the safety? If you see the safety, the fixed dose combination has a safety profile comparable to its monocomponents, saxagliptin and dapagliflozin, including low risk of hypoglycemia. So hypoglycemia is less, 1.4% compared to saxagliptin and metformin and dapagliflozin plus metformin. So when you combine, it is less. CV events is beneficial. Urinary tract infection is less when they are when even dapagliflozin is given as is comparable. So adverse events are not. If you see this here, vulvovaginitis and balanitis and related genital infection, the combination is giving a lesser percentage of people have these complications when they are given just dapagliflozin. So adverse events are less when you give this fixed dose combination along with metformin. Dapagliflozin had significant reduction in the composite of hospitalization because of heart failure and CV death, and this was a well presented study. And if you see, there is almost a reduction of hospitalization because of heart failure and CV death, and even 3-point MACE. So this is a class of drug which has got a lot of advantages even in the patients with heart disease. And saxagliptin metformin, the primary endpoint of CV safety, 3-point MACE, it was neutral. Hazard ratio was 1, so it was non-inferior. Neither it was superior nor inferior, it was neutral in the severity trial. So did we get the required attributes from Saxa DAPA fixed dose combination? Yes, we can have a weight glycemic control. We can have a weight management in obese people. We can have managing comorbidities like hypertension and safety, including low risk of hypoglycemia. So this is what we are looking for in our patients with obesity and uncontrolled type 2 diabetes. So to summarize and conclude, DAPA and Saxa fixed dose combination addresses patient preference for oral therapy by allowing them to continue an oral therapy and delaying the need for injectables. So this is only good for patients who have HbA1c less than 9%, not patients who are having a HbA1c of more than 9.5 or 10%. You have to be very, very careful in in selecting your patients. So this is what is the need of the day. Most of the patients actually quit therapy because of the injections. So patients, you put them on this particular combination therapy, they have delay in onset of insulin therapy. So patients ranked method of administration is one of the most important reasons for their treatment preference. Value to the patient is significant reduction in A1C and patients getting to goal, weight loss and blood pressure benefits, reduced pill burden, acceptable safety and tolerability, including hypoglycemia risk, and economic benefits. So if you put a patient on dapagliflozin and saxagliptin combination along with metformin, almost the chances of getting hypoglycemia is very less, and they have economic benefits by not getting severe hypoglycemia and having benefits of not getting micro and macrovascular complications. So what is the status with the existing drug classes? If you see, sulfonylurea can cause good glycemic control, but at the cost of hypoglycemia and weight gain. Otherwise, they are neutral for blood pressure, cardiac, and renal parameters. PZDs are having again a good glycemic control, but it causes weight gain, edema, and it can increase the risk of heart failure. DPP-4 inhibitors are neutral all over. GLP-1 receptors are high and they're good for weight management and cardiac, but cost is a concern with GLP-1 and it's an injectable therapy. AGI, they are intermediately glycemic control, and the hypoglycemia is neutral, weight is the beneficial, blood pressure, cardiac, they are all neutral. Insulin is again high glycemic control. Then hypoglycemia is it's a concern, weight gain is a concern, and BP, cardiac, and renal safety are neutral. ACLE2 inhibitors, intermediate glycemic control, and if you see, the hypoglycemia is neutral, and you have all these advantages, weight, BP, cardiac, and renal. So these are the class of drugs, except for sulfonylurea and insulin. You see, most of the drugs don't cause hypoglycemia. Even in our country, we use a lot of alpha glucosidase inhibitors, like we use acarbose and voglibose. They are also a very good class of drugs that can be used in our patients. So Declare becomes applicable to all these patient profiles, that is patients having a poor diabetes control, patients having obesity, patients having hypertension, and patients having dyslipidemia. All these patients can be put on patients who have atherosclerotic cardiovascular disease, which predominates, heart failure, which predominates, CKD, which predominates, and even in patients who don't have ASCVD, heart failure or CKD, but they have multiple risk factors like our patient. That is the primary prevention. You can use drugs like ACLE2 inhibitors to reduce heart failure and to increase renal protection. So with the CV benefits of ACLE2 inhibitors and CV safety of DPP-4 inhibitors, it seems to be a synergistic pair, be it for CV renal or for HbA1c, and DAPA-Saxa glycemic efficacy is equal to insulin with benefits in terms of weight and systolic blood pressure reduction. This is very, very important. I again keep repeating it, that this is only with people who have an HbA1c between 8 and 9, not with people who are 11 and 12% of HbA1c. And use of DAPA-SEXA combination is associated with better urinary albumin-creatinine ratio outcomes. This should translate to CV effect, and it was well documented in even the sub-analysis of SAVOR-TB trial. Safety of DAPA-SEXA is well established. So I thank you all for your patient listening, and I thank the organizers for giving this opportunity. So we can have questions and comments.
Any questions, comments from the chairperson? Doctor?
Can I come in, please, for a second?
Yeah, sure.
Good afternoon, Dr. Dhandhania, sir. This is Dr. Ajay Chabra, this side.
Yeah, good afternoon. I can see you, Ajay. You're looking smart. Headphone.
Thank you so much, sir. And it's so nice to see you on this holiday afternoon. My question with DAPA-SEXA combination is that we have known that sexagliptin causes increase in heart failure among all the DPP-4 inhibitors. SEXA is the only one which was implicated to have increase in heart failure with hazard ratio of 1.27. Yep. So do you think the DAPA effect and the SEXA effect, they are both going to neutralize each other?
Definitely, yes. But at the same time, I would say if you see the sub-analysis of patients going into hospitalization because of heart failure in that SAVOR-TB trial was only in a group of patients who had got a reduced ejection fraction, reduced EGFR, not in a group of patients who had normal renal function. So in those group of patients who are at a very high risk of going into heart failure, only those were the group of patients who had higher incidence of hospitalization because of heart failure. And those patients definitely had a lot of other comorbidities as well. And if you see the inclusion of the patients in SAVOR-TB trial, where the hospitalization because of heart failure was high, it was very high risk group of patients who were included in the SAVOR-TB trial. In the later studies, which was TCOS and Examine and all the other studies, the risk of patients were well neutralized before the inclusion criteria. So I'm sure you will definitely get the benefit. But if you see our patient who are a 45-year-old male, who is a diabetic with a HbA1c which is high, who is an obese with a body mass index of 32, who is having a blood pressure of 150/90, and who is not having a heart disease, I think these are the type of patients who will most benefit from this class of drugs, with this combination of drugs along with metformin. And they can definitely consume these drugs for longer time because of the lesser chances of getting into hypoglycemia and the lesser chance of getting into complications of therapy.
Absolutely. So there is a clear subset of patients who would require this combination and who are going to benefit a lot from this combination.
Yeah.
Yes.
I think we should focus on those class of patients instead of putting high risk group.
Yes, absolutely. Yes. Yes.
Thank you so much, Vinay Bhaiya. Thank you so much, sir.
Good going, Vinay. You're doing an excellent job. We are proud of you.
It's your blessings from you only.
Excellent job.
Aryam.
Thank you very much. Thank you.
I also request our chairpersons to kindly Aryam फिर अटक गई slide. our chairpersons to kindly accept the certificate of faculty: Dr. Kapil Mahindra, Dr. Kumar Gaurav Sharma, Dr. Manoj Gerela, and Dr. Deepak